I am Dr. Shabuño. I am a director of breast imaging and ultrasound in Tampa, Florida at Moffitt Cancer Center, and today I will be talking about breast elastography. Hello, my name is Dr. Shabuño, and I will be giving a talk about breast elastography. Elastography is an imaging technique that depicts tissue stiffness by means of imaging tissue strain from external compression. A software technique integrated into the ultrasound system without any external equipment is utilized. Same probe is used for the B mode and elastography ultrasound imaging. The elastographic information is obtained in real time, and it only takes a few minutes, anywhere from 2 to 5 minutes. Based on a principle which is similar to palpation, that's what elastography technique is all about. On physical exam, as you know, tumors feel much harder than the surrounding tissue. With compression or vibration, when it is applied to the soft tissues, ultrasound then can be used to create a map of soft tissue deformation. The results are displayed on an image called elastogram. The elastogram generates a display of relative stiffness of the lesion to the rest of the image on a color image. And the main colors that you will be seeing are blue, red, and green. Blue will represent stiff lesions, red and green represent soft lesions. It is important to have the surrounding tissue included in the image, and we will be using a scoring system which was developed by Dr. Ueno from Japan. This is a diagram of all the scoring from 1 through 5. I will be going over each one separately. This is just to give you an overview. And as you go from 1 through 5, the 1 represents the benign lesions and the 5 represents the malignant lesions in progression. The green represents the greater strain. That's why it is soft and it looks green on the images. And the blue represents a smaller strain, and it is represents a hard lesion. The real-time elastogram is superimposed in color on the B scan using a freehand scanning technique, and both are seen on the monitor with the B mode on the right and the elastogram on the left. This is an example of an elastogram of a simple or complicated cyst, and it has a specific appearance of a 3-layer pattern where you can appreciate the blue, the green, and the red. So this is fairly specific for a cystic structure, and we all recognize it as such. The compression, when is being applied, is very important that it is applied in a very light touch. I refer to it as a feather touch. You need to use a lot of gel. There has to be a steady compression, and the compression of normal tissue is necessary to obtain the uniform image of the green. Then the area of pathology is then investigated using the same compression. This is an example of a breast tissue, normal breast tissue. This is the skin, and this is a fairly glandular, dense tissue. And on elastogram, you can appreciate mostly the green and the reds, which imply that this is a fairly soft area or normal breast tissue. On a elastic score of 1, you will see an even strain over the whole lesion, which is green, as well as the surrounding breast parenchyma. This would be an example of a fibroadenoma. Another example of a benign lesion, which is seen on an elastogram, would be a typical hypercoagulabulated lesion, which is parallel to the skin. However, when you apply the elasticity, you notice that the lesion is all green, and it is surrounded by fairly soft parenchyma, which is red or green, and this is a fibroadenoma. This is an example of real-time scanning with elastography, where you are applying pressure to this very light pressure, and you notice that the actual lesion and the surrounding tissues sort of blend in together. They all are either green or red, which implies that they are soft, not stiff. And on the gray scale image, this corresponds to a lobulated lesion, and this was a fibroadenoma, and this would be given an elasticity score of 1. The elastic score 2 demonstrates strain over the most of the lesion, with some areas being spared, and they are shown as mixed green and blue. It is normally seen with fibroadenoma or complex cyst. However, I would like to show you this particular lesion with the real-time clip, again demonstrating that when you do the actual compression, which are fairly light, in this case it shows both blue and green areas, which would be typical of an elastic score number 2. However, if you evaluate the actual B-mode image, you notice that this is not a very lobulated lesion, but it is lobulated actually, but it does have some areas of angular margins, and it does have posterior shadowing, so that would be more suspicious for a malignancy, and probably a score of 4B or 4C. And this turned out to be a invasive ductal carcinoma after performing a biopsy. So the point of this case is that for final assessment for lesions, you need to do both the grayscale imaging and the elastogram as a single package, and then decide based on the worst characteristics, which are we dealing with a benign or malignant lesion. And as with using the BI-RAD system for any kind of lesion, you always go with the most worrisome finding, and in this case would be more of the angular margins and the posterior shadowing as shown. For elastic score number 3, the strain is at the periphery of the lesion, where it's mostly green and the central portion is blue. This is often seen with intraductal papilloma. I am showing you actually a case of a fibroadenoma where you have centrally stiffness of image with blue color, and then around it there is the green, and then surrounded by red. So this was a fibroadenoma. Elastic score number 4 has no strain over the entire lesion. It's completely blue, but it is surrounded by the green normal parenchyma. And this is always seen with most of the time seen with carcinoma. This is an example of a 39-year-old woman with invasive ductal cancer. And on the B scan, you can appreciate a lesion that is irregular, has angular margins, has some posterior shadowing, and on the elastogram, you appreciate that the lesion corresponds to a blue area, and it is surrounded by benign parenchyma, which is green and red. Another lesion which would be difficult to distinguish on B scanning itself, because it's hypoechoic, fairly well circumscribed, but has posterior enhancement, and this could represent a complex cyst, but we cannot exclude a solid lesion, so we would definitely biopsy this, but with the help of elastogram, we are seeing that this is all blue, which would be consistent with score 4, and it's very suspicious for malignancy, and this was, after biopsy, a lobular carcinoma. The elastic score 5 demonstrates no strain over the lesion and also includes the surrounding areas, and is depicted as blue, and it's often or most of the time seen with cancers, which are usually the lower or mid grade cancers, which tend to have desmoplastic reaction. This is a nice example of the lesion, which is very irregular with posterior shadowing, and when you look at the elastogram, the actual blue area is larger than the one depicted on B mode. This was grade 2 invasive ductal carcinoma on core biopsy. Malignant lesions tend to be larger on strain images than on corresponding B mode images, potentially because of the surrounding desmoplastic reaction that accompanies most of these malignancies. And that's what we would see on the elastogram, a lesion which appears larger than on B mode. There are certain studies that have been performed. One of them is by Dr. Ueno himself, and he has found that most malignant lesions are either have either a score of 4 or 5, and then he has not found one malignant lesion associated with a score of 1. Most benign lesions are either 1 or 2, and his results showed that elastography showed a sensitivity of 86.9, specificity of 92.1, and an accuracy of 89.8%. There is a multi-institutional or multi-center clinical trial that was performed in Italy, and these findings of this trial were presented at RSNA in 2006. 874 lesions were evaluated. 614 were benign and 260 were malignant. The evaluation with real-time elastography showed a very high specificity in benign lesions, including BI-RADS 3 lesions. The negative predictive value was 98% for all the lesions and 96.3% for all the BI-RADS 3 lesions. Real-time elastography does help conventional ultrasound in characterizing breast lesions. There is a French multicentric prospective study utilizing 345 lesions in patients in 314 patients. This was presented at the European Congress of Radiology. Elastography for the lesions of all sizes achieved sensitivity of 80%, specificity of 93%, and positive predictive value of 85.3%. The negative predictive value was 90.3%. What's interesting about the study is that the sensitivity was best for lesions that were less than 5 millimeters, which is very helpful because those lesions are not well evaluated with B mode. So this is a great tool to help further characterize these lesions. There is also a study that was conducted with the Italian group led by Dr. Martina Locatelli, was presented at the European Congress of Radiology in 2007. It was a multi-center study, and the study demonstrated a negative predictive value for BI-RADS 3 and 4 lesions to be 98%. And again, interesting finding, lesions that were less than 5 millimeters, the negative predictive value was 100%. So in conclusion, the real-time elastography helps conventional ultrasound in characterizing breast lesions. Complementary sign, it is a complementary sign to the B-mode imaging, and it's highly specific for BI-RADS 3 lesions, and it decreases false positive biopsies. Elasticity imaging may eliminate the need for biopsies, resulting in significant cost saving for the health service. Currently, about 80% of breast lesions biopsied are benign, according to the American Cancer Society. A large multi-center study is needed to validate these findings and to determine accuracy of this imaging technique. I would like to present you with a case of a 59-year-old female with an invasive ductal carcinoma in her right breast and a suspicious right axillary lymph nodes that were documented on MRI. This is the B mode and the elastogram of this lesion, and it has a score of 5 because the lesion on B mode, on the elastogram appears larger than the one on the B mode. So it was given a score of 5, and the biopsy demonstrated a cancer. But because the lymph nodes were abnormal on MRI and ultrasound was performed, and we were trying to decide based on ultrasound imaging whether these were abnormal lymph nodes. So we could not determine from just grayscale imaging whether this is benign versus malignant. using the short to long axis diameter ratio, in which case, in this case, which was 0.53, which was greater than 0.5, Dr. Lishik has demonstrated that most of these lesions would be metastatic lymph nodes, 75%, but 18% of those could be benign. So ultimately, you need to perform a biopsy. And since we were studying the actual mass with the elastography, we then decided to also investigate the lymph node, and it shows a classic score 4 lesion, which is consistent with a malignancy. Since ultrasound cytology can yield false negative results, elastography seems to have a potential to improve that accuracy of percutaneous biopsy. In our situation, when we biopsied that node, the results came back metastatic carcinoma, and basically it staged the patient, and she did not have to go through the sentinel lymph node. And as a result, again, we are trying to reduce the cost of medicine by performing these procedures. So this also seems to have a great value, especially in breast imaging. Possibly in any other cancers that are often the lymph nodes are evaluated would be melanoma, and we may be able to perform elastography on these lymph nodes and maybe make a decision whether we should biopsy them or not at that time. I thank you for your time.